Good evening. This is Steve Cole coming at you from the Ada County Paramedics Education Department. We have another little bit of education for you. Today we're going to introduce something called the Code Critical Program. And hopefully by the time we're done with this, you'll have a pretty good buy-in to the process. So our learning outcomes for today include we're going to review the criteria for what we're calling the Code Critical Program, and we're going to hopefully give you some information to apply it to everyday EMS operations, and with the goal of reducing people that currently fall through the cracks with our other, what I like to call our other code word programs. So let's just jump right down to it. We've had a pretty good relationship and a lot of success with other specialized patient programs with the idea of getting the right patient to the right time and the right resources when we walk through the door. And what I'm talking about are the trauma priority patients, the code STEMI patients, and the code CVA or brain attack patients. The problem is that more routine critical patients have sometimes fallen through the cracks. We're talking about the codes and the post codes, those with respiratory failure, we've intubated, we put CPAP on, or other patients who are unstable and they're critical, but they're kind of not the big, I don't want to say big ticket items, but not the more guts and glory STEMI and stroke and multi-system trauma patients that we have processes in place. And the result is that sometimes we walk in, we get a great response. We have the physician there, and we have everybody else there, RT, in a nice, well-lit room that is prepared for resuscitation. And sometimes we're put in a room where we're not met with anybody. And then we look at the programs that do work, and we look at this, and it's very frustrating. So we've tried to address this before, and haven't had a lot of buy-in in the past. I think a lot of that is because this is, by definition, this is something that occurs as a gap in process before the patient arrives at the hospital. Usually, once the nursing staff sees the patient and their level of critical acuity, they usually jump into action. What we want to do is to take that action and make it consistent, and we want to make it as part of a process, not based on who happens to pick up the phone and whether they hear sirens in the background or not. So we had difficulties getting in the past, so we decided to get some data, and we got data in the form of a survey. You might remember this have gone out a little while ago for the Ada County people watching this slide, and we surveyed our providers with some, just to get some basic information. Now, this survey certainly wouldn't rise to the level of scientific inquiry, but it did give us some interesting data that wasn't surprising to us, but was surprising to some of our partners. Now, about approximately 120 people we sent the survey out to. 65 providers responded. Of those 65 respondents, all, of course, were in one form or another part of Ada County Paramedics. We didn't distribute this survey outside the department. Survey participation was voluntary, and we got about 55% return rate, which is really good for a voluntary survey of this sort. It's excellent, as a matter of fact. Usually you're expecting between 10 and 30%. So pretty happy with that. So we wanted to know if the people responding, if they would be in a good position to understand the issues, the questions that we were putting out, and respond to them appropriately. Well, all of them obviously were EMS providers, and the majority of the responders were paramedics. Now, this is pertinent because in these critical patients, it would be paramedics predominantly taking the lead, being responsible for the patient, and being in a role to advocate for the patient. Now, we also want to know if they had enough experience to recognize the issues and if they had enough experience to be exposed to them and have a valid opinion on this. We want to make sure that when we put this survey out that the people that we're getting data from were in a position to comment. So we surveyed experience as an easy surrogate for that. And just about half of the people that responded had over 10 years experience in EMS. So we could definitely classify them as experienced EMS providers. Substantial portion of them about 12% of them, which is still substantial, had over 20 years experience. Over 2/3 were what we would call had at least 5 years experience or more. So that included everybody 5 years, 10 years, 15 years, 20 years. So only about 10% had less than 2 years experience. So overall, pretty good spread. Now, when we look at the 10% that had less than 2 years experience, most of those were reserves or they were brand new hires. So good study sample, good group of people to survey about this issue. Then what we want to know is, of this group, we validated that they're in a position to have a valid opinion on them. Let's see what their opinion is. And we asked them if they had ever experienced a case where they had a critical patient who was not a TSE patient. By TSE, I mean trauma, stroke, or STEMI, the time-sensitive emergencies, TSE. If they had a patient who was not a TSE patient but who is nonetheless critical, if they'd ever had a suboptimal response, in other words, gone into the ER and they weren't ushered to a resuscitation room, they weren't met by a physician, they weren't met with the resources that they thought that the patient should have based on their radio report. And of these, 61% had personally experienced it in the past 12 months. That's pretty substantial. 26% of it had, while they had not experienced it personally, they had heard of other providers experiencing it within the past 12 months. And only 13% had neither heard of it nor experienced it. Now, so basically what that means is approximately 87% had some exposure to this. Of the 13% that didn't, almost all of those were the providers with under 2 years of experience who were either reserves or brand new hires and thus had limited exposure in the system due to the volume of calls they'd been on at that point. So again, what we were able to paint this as or present this as was that this is a prevalent problem. And this is no surprise to anybody that actually works in almost any EMS system anywhere, I would suspect. So we know that what we're doing now is not working. And when we say not working, it's not getting the resources that at least we think should probably be mobilized for these critical patients when we walk in the door. But so before we invent a wheel and try to create a process, brand new process, let's look at some things that do work. So again, we keep going back to these TSEs, these time-sensitive emergencies, trauma, stroke, and STEMI. So we looked at trauma, stroke, and STEMI, and we did this using a Likert scale. And a Likert scale is a 1 to 5 scale that is very commonly accepted in surveys at this point in the scientific and research community for qualitative surveys. And when you look at one of these, if you've ever taken like a patient or customer satisfaction survey on a 1 to 5 scale, that's a Likert scale. With 3 being a neutral, 1 and 2 being usually negative, 4 and 5 degrees of positive. Anyway, so we surveyed paramedics and EMS respondents, I should say, not just paramedics, and asked them if they thought the current trauma priority system, how effective it was at mobilizing resources for the patient when you walk in the door in a systematic and predictable manner. And 78% of them reported it as very effective. They're very happy with it. 20% reported it as somewhat effective, and only 2% reported it as seldom effective, and nobody reported it as not effective at all. So that's a pretty good endorsement of that type of process. So let's see if it's something that's specific to trauma priority, which is specific to a certain hospital in our area, or is this something we can extrapolate to our other TSE programs that involve all the hospitals in our area. So we're trying to see if this is facility specific or it's process specific. And so we looked at code CVAs, brain attacks, and again, a high level satisfaction. The average score, or the mean score on this, was 4.62 on a 1 to 5 scale of the Likert scale. If you look previously, it was 4.75 for trauma systems. So a touch less effective than that, but still a very strong endorsement for this type of process from our paramedics in the field. Let's look at STEMIs. And we found similarly a 4.67 mean. So in this case, we had the blue column is people who said it was very effective. The purple column is people said it was somewhat effective, the 4. The yellow column, people who were neutral, and only one person, one negative Nancy, who said that it was not very effective. So again, in this scale, we see a lot of support for this type of process from our field providers. They're pretty happy with it. We put them side by side as a graphical interface, as a graphical representation, and you can see again just how much the difference is. A lot of people are very happy with this. So we wanted to see if what we're doing outside of these code word programs to see how they rate up. So we were looking at, there's a lot of text on this field, but short version is we were looking at a simple radio report with no special request. We were looking at when you give your radio report and then you say that you need a physician at the bedside. Or we also looked at when you request some other specialty resource, such as a RT or anesthesiologist or something like that. So these were the 3 most common modalities that we, when talking to our field providers, that they usually do to try to make sure that they had extra resources for the patient who was critical but not one of these TSC patients. And we had mixed results, considerably less. We found that compared to scores in the 4 range, the standard radio report was barely above neutral at 3.23. Requesting a physician to the bedside actually did worse than a standard radio report in perception at 3.14. Requesting RT or something like that to the bedside did a little bit better at 3.28. So again, these are not strong endorsements of the current processes that we have in place, but as a graphical representation, we put them all there side by side, and you can see that very few people rated these as very effective. Most people rated them as somewhat effective, and a substantial portion rated them as either neutral, not effective, or seldom effective. So a much broader spread and not nearly as much support for just leaving things as they are. Put them side by side. As you can see, our medic there is kind of, our Fallout Boy is a little bit upset at this idea. All right, so we look at this and we put them side by side, and you can see a dramatic difference between the perception of the effectiveness of the processes for TSC emergencies and the effectiveness of the processes for these routinely critical patients. So what does this mean? It means that we have some work to do. It means that the code word systems seem to work, and it means that when we don't use them for critical patients, things fall apart. At least that's our perception. Again, this survey was on perception, not on actual performance. So then we asked people, well, if we were to do a new code word program, whatever it was, for these routinely critical patients, do you think it would be effective? 22% of people surveyed said, yeah, I think that's a good idea. 44% were like, yeah, I think it'd be somewhat effective. Overall positive. So that, between those two, is over half. Another 24% were like, I'm not sure. Only 10% were like, nah, it's not going to work. So again, I would take this to mean that, at least in our system, our field providers are generally supportive of the idea. So let's say, well, what would trigger one of these rapid responses? What criteria should we roll into a new code word program for these critical patients? What constitutes a critical patient? So I threw out a whole bunch of stuff, everything from shock index to intubated, and to GCS at different levels. And you can see that some of these I put up here. There was a lot of support for some of these, and not so much for others, and some poor support for others. So the ones I have up there are the ones that scored better than neutral. And the ones I was really interested with at the beginning are the ones that were definitively positive, which is 3.5 or higher on the Likert scale. Again, we keep using the Likert scale because it's easy to compare and benchmark. And here's where we were, and here's 3.5. And the stuff that made the cut were things that you would predictably think, oh yeah, that's a no-brainer. Intubation was above 4.5. Post-ROSC was at 4.5. Impending airway failure at 4.43. Some of the ones that didn't do as good, such as severe pain or discomfort, was overall a negative score, or not negative score, but below neutral at 2.48. The shock index, I think part of that was lack of familiarity with that, didn't score as high. You get the basic idea. So looking at this across the spectrum, we had a place to start. Now, it's important to note that these are not the final criteria. The final criteria were determined in collaborative meetings we'll talk about in just a few minutes. So some of the stuff that didn't make the 3.5 cut got added in, and a couple things got dropped out. But this was based on talking to the hospitals and looking at what their internal processes were. So we want to make this process not something that we drove, but that the hospitals drove. So now that we have the information, what did we do with it? And as I just said, we met with the stakeholders. We met with the individual hospital representatives, nurse managers, so on and so forth. And we had meetings. And we had more meetings. And we had more meetings. And more meetings. And even more. But these were actually productive. They involved the RICE, the access agencies. Canyon County paramedics really went above and beyond to help get the buy-in of some of the facilities on their end so that we're all using the same process. So I got to give them prompts. So all of the access agencies, Ada County, Boise Fire, CUNA Fire, Meridian Fire, Eagle and Star representatives have been briefed and are bought in on this. The access medical directors are in on this and are copacetic with it. The agencies it's going to affect the most, of course, are going to be Ada County and CUNA because we're the transport agencies. But everybody needs to understand these basic principles. What's really important is we got we did a presentation at the TSC, Southwest TSC committee meeting, and they were in support of it, actually pretty strong support of it. St. Alphonsus, who already does stuff like this a lot, probably the first ones in the Valley to do something like this with their trauma priority, the old trauma leveling system that has gone back over 2 decades. We're in support, and their medical access center has reviewed this as well. St. Luke's, their nurse managers and their processes have reviewed this and are dialed in. And even West Valley is spun into this mix and have had input and have been very effective with this. So pretty happy. We've got a lot of buy-in. All the major hospitals in our area have participated in discussion, added their input, and this is where we are. Now, the only one that hasn't has been the VA system, but most of these critical patients don't generally go to the VA anyway. They usually divert them. But we'll get them spun into this also. So when we look at this, and we look at the specific hospitals, I may have left one out, I'm not sure. Of course, the main campuses for St. Al's and St. Luke's, the St. Al's Eagle, freestanding ER still has a process in place. St. Al's Nampa, St. Al's Garrity, St. Luke's Regional Medical Center, St. Luke's Meridian, St. Luke's Nampa, and West Valley. All the major players. Everywhere you're going to transport in the Valley, in the Treasure Valley, we have right here. So a question that you might have is, does this change our destination protocol? And the answer is no. This changes processes for once we arrive. It doesn't change the destination. Our destination protocol seems to be working fairly well. I'm sure that everybody might have one story or another anecdotally, but the overall impact, it seems to be working. The right hospitals or right patients are going to the right hospitals most of the time. What we're looking at is what happens when we walk in the door, the process there. Now, some hospitals have what they call rapid reaction teams, rapid response teams, medical response teams, MERTs, medical emergency response teams, lots of different stuff, which leads us to why we chose Code Critical. And the answer is, this was what we discussed with the hospitals based on the criteria, so it didn't confuse with their internal processes. We wanted a code word so that everybody would be dialed in that wasn't going to be mixed up with something else. So let's get to the criteria. What are the criteria? Well, we base them around simple airway, breathing, and circulation. So let's look at the airway criteria. The airway criteria, obviously, any advanced airway and praise. That's a King, LMA, ET, iGel, something that comes down the pipe later on. Any of those advanced airways, you crack them, it should activate this response. Now, the exception to this would be those that have trachs in, that have had trachs in. Those don't get a rapid response unless there's an issue with placement. So if it's been dislodged, if you can't get it back in, if it's otherwise got an airway issue with it specifically, even though it's long-standing, that would trigger it. But just having a trach, doing an interfacility transfer with a trach, that a patient that happens to be a trach, doesn't trigger this. The airway issues, as impending airway failure, such as anaphylactic angioedema, ACE inhibitor angioedema, or airway burns, will also trigger this impending airway failure. Now, this is kind of in the eye of the beholder a little bit, but as we'll talk about in a minute, we're talking about the clear-cut cases. Or somebody who has a GCS less than 8, or who otherwise can't control their airway. Now, if I can control their airway with a little jaw thrust, I'm okay with that. But if I'm having to actively suction them and using apneic oxygenation and other aggressive measures, that's not controlled the airway. I'm managing the airway, if you can appreciate the difference there. Let's talk about respiratory criteria. If we have to acutely place CPAP in use, so if they have CPAP as a matter of routine and they are you're doing a transfer, interfacility transfer where CPAP's in place, probably wouldn't trigger this. We're talking about acute CPAP use for a respiratory emergency of some sort. Again, a vague comment or vague criteria that is in the eye of the beholder, but impending respiratory failure. I would caution you, however you qualify this, whether it's based on end-tidal CO2 or whether it's based on a work of breathing and they're tiring out, I would just make sure it's pretty clear-cut. And of course, if you have to actually bag them, even if you don't have an OPA in, if you're having to bag them, we need this rapid response activated. Now we look at our hemodynamic criteria, our circulation criteria. The obvious one is code blue and post-cardiac arrest, and this should seem like a no-brainer, but talking to a lot of providers, this was one that was falling through the cracks, particularly post-cardiac arrest. So we rolled that into this. Now, understanding that you need to make it really clear that's a post-cardiac arrest because some facilities need to activate additional resources for that, such as either their hypothermia protocol or their Lucas. We talk about hypotension less than 90. What we're really talking about is symptomatic hypotension. Symptomatic hypotension. So if somebody just lives around 90 due to their overall health, and they aren't acutely symptomatic, they aren't passing out when they're standing up, they're not altered in meditation, they aren't having chest pain and such with that, they wouldn't trigger this. It has to be symptomatic, severely symptomatic. Same thing for symptomatic bradycardia, less than 40 in adults. Now, this could be, again, if you have the marathon runner who for some reason is right at 40, that'd still be pretty low, but they're right at 40. Or somebody who's on beta blockers who's at 46, but they're tolerating it well, they're not grossly symptomatic, they don't trigger this response. What we're looking for are the patients who are truly at death's door for this. Now, I'm sure some people are going to ask me about sepsis, and we have a placeholder in this program for sepsis, but we don't have criteria defined yet. That will probably be defined at a later date in an update. The reason is that we know that TSC at the state level is developing sepsis criteria, and they may actually be developing a completely new category, a sepsis category to go along with the big three. So we're kind of waiting to see what happens there. So there you go. Now, whatever you do, we want you to keep in mind that when you do this, it disrupts workflow. Workflow of the physicians, workflow of the nurses. It pulls them away from their patients they're already caring for and whatever they're doing to stand by to wait for your arrival. So we want to make sure that we don't do this needlessly. We don't want to waste resources, and we don't want to predispose ourselves to alarm fatigue, where the staff gets so used to hearing us calling code critical, they don't give us credence and the process falls apart. We also don't want this to damage their perception of our competence and able to determine who needs this and who doesn't. So at the end of the day, we just want you to be cautious that you don't cry wolf, that we want you to make sure that the people you call this on they do need this. Pretty self-explanatory. Now, I always get asked, well, what if my patient is both a code critical patient and a TSC patient? What if they're a STEMI and their heart rate's at 39, or they're a STEMI and their blood pressure is at 88, or they're a stroke and they can't control their airway and their GCS is less than 8? Which do I call? Well, as a general rule, the more specific TSCs take precedence over the code critical. That's it. So if you have a stroke that also is code critical, you call it in as a code CVA. If you have a STEMI that's also code critical, you also call it in as a code. You take them to a code STEMI facility. And that is pretty much it. So if you have any questions, contact us. We'll try to answer them in an update. Thank you for your time.